So revisit means our own knowledge, we are going to introspect and we are going to revisit complete dentures to find out what we do and what we can do differently. So that's what my motto here is today, to stand and speak to you. If you have anything to ask, you can always put your hands up and I will answer your question. So complete dentures, we are all looking so happy. Have you ever thought of a complete denture patient who comes to you? Most of them are in the part of their life when people don't care for them. How many of you all really think that when a patient walks in, what is his feeling? Why has he come to you? Has you come only for a denture or more than that? Try to think. A little philosophical part I'll be talking to you is that when you're talking to this patient and you think that why this patient has come, the first thing is we people have forgotten how to prepare a complete denture because we are only thinking of what? Of running to make an impression. Most of us have done that and most of my students do that. When I asked them, I said, patient has come, I said, let me know what you're going to do. मैंने मैं impression ले लूँगा. Impression ले लूँगा means क्या? Why do you want to make an impression? The patient has walked in, do something more than making an impression. So why do you think we should discuss this topic? First is, it's the first prosthesis that is taught to you. You remember when you came into first year and you went into the lab, what was given to you? 2 casts. And you were told, draw them out. Draw the areas which are primary stress bearing. Something was told to you which you never understood why it was told to you. But that was the introduction to dentistry. Other subjects were all anatomy and physiology. But the first subject which was taught to you was complete dentures. And we started with complete dentures. But unfortunately, when we come into the 3rd year, we all have a single demonstration. Just one demonstration. And in some colleges, they have a demonstration today and the person makes an impression after 1 year. So you are all confused. There's a confusion in what we are taught at the undergraduate level. And then suddenly we realize that we know very little. We go into practice. And in the practice when a patient comes to you, what do? You call it prosthodontics. Because you have not learned enough during the time of your undergraduate training. And you're confused about what was taught to you. You're not practiced enough. And the best thing is to avoid a complete denture patient. Avoid him like the plague. Don't allow him to enter your clinic. But you don't understand that one complete denture patient will earn you 20 more patients. How? So I always tell my students, how? That complete denture patient has no work to do. So he's old, he's retired. What is he doing? Morning he goes for a walk, evening he goes for a walk. Then he sits on the roadside or in the garden and talks to 10 people and says, oh, that Dr. Ram did very bad work for me. Don't go to her. Alright? Another one says, Dr. Akshay Bhargav, the dentist, what work he did. I only go to him, I'll not go to anybody else. And you know what? My daughter-in-law went to him and he was so nice and so polite and so concerned. And that is why I'm here. Because I'm smiling and talking to you. It's so nice to go to that dental clinic. And he sends his daughter-in-law, he sends his son, he sends his wife, he sends all his friends. And what have you made? You made your clients. And you made your clients by whom? With one complete denture patient. So try to understand, if you deal with one complete denture patient with affection, with concern and dedication, I'm sure the practice will be roaring. So please remember, do not have a complete denture patient just thought of a patient who's come to you, who cannot pay, and that's why you will not have him given that importance. Now I would be considering my talk under these headings: the introduction to complete dentures, the examination, which I think is the most important part of a complete denture, Then diagnosis and treatment planning. Importance of various steps. I'm just trying to take up each step and try to make that a little interesting for you. And some special cases like gagging, salivation. What would you do in those types of cases? So complete denture, all of you know, and patient has lost all his teeth and he's edentulous and he's come to you. So we also call them as dental cripples. Why we call them as cripples? Think you don't have a leg, you don't have a hand, you don't have a finger. You are a cripple. So imagine such an important part of your body is missing. Just imagine if one tooth breaks, we are so worried. And that poor patient does not have any teeth in his mouth. How he must be feeling? Have you ever thought of it? Only when we are in that person's shoes can we imagine how that person will feel. So stand in front of the mirror, smile and put black over your teeth on the mirror and see how you look. You'll realize how ghastly we look without teeth. All of us, the first thing actually when I look at a person is the smile of the person. Always you notice, the person walks in, I always say, you smile with your teeth, but the smile is in your eye. You look at the teeth and then you look at the eyes. Why? Because that twinkle in the eye is very important. So unless he has teeth, he'll never have a twinkle in his eye. And that's when you're taking pictures of your patients also. Make them smile, but they must smile with twinkles in their eye. That's very, very important. Right? So you know that complete dentures, I don't have to do a definition, but just for you, the definition is there. What are the problems of dentures? Have you ever thought of it? Why am I here? What is he cannot go out because he's got low self-esteem. He doesn't have the confidence. Many times when probably the girls will understand it better, you've gone to the parlor and the parlor person has not done your hair properly. I'm not going for the party. I'm not going in front of anybody. Why? Because I'm not going to look good today, and definitely if I go there, people will think I'm not looking good. So my own self-esteem goes low. And I don't want to appear in front of it. So imagine these people don't have a smile because they don't have teeth. So you can imagine what self-esteem the patient will have. The patient will feel really very, very low. The second difficulty is mastication. You know, when you ask a patient, old patient, and you ask him that why do you want teeth? He being old doesn't have to look good, okay? That's what he thinks. And you think. But his dill doesn't think that. You feel patient doesn't, हमको खाने के लिए चाहिए. आपको अच्छा नहीं दिखना है? हाँ, अच्छा दिखेगा तो अच्छा ही है. अच्छा आपको अच्छा नहीं दिखना है कि खाना खाना है? नहीं, अच्छा भी दिखना है ना, फिर मेरी बहू क्या बोलेगी, मेरा बेटा क्या बोलेगा? So, but natural that he wants to look good too. So, you have to have first think. When I come to the chief complaint of the patient, I'll tell you that we need to know what is this problem. So, we have a number of problems in it. Speech, definitely, when he talks, does fuss. He can't speak properly because these are very important part of speech. If you go into the phonetics of complete dentures, you will realize even contouring of the palate, placement of the anterior teeth, placement of the lower anterior teeth, how it will affect the speech. So imagine no teeth. Even some people who have teeth, but they do not have proper placement of the teeth. You have a problem in speech. So speech is a problem. Then he had a senile look. Who wants to look old? I don't want to look old. You're all young people. I won't say I don't want to look old. 62, I want to look young. So all of us want to look young. So if a patient is given back his smile and his denture, the vertical dimension is correct, the patient will not look old. Annular cheilitis, this is something which most of us observe and don't observe. The patient comes to you. You have nice areas inflamed in the corner of the mouth, and because he has no teeth and he has drooling of saliva and then infection sets in, you have an inflammation over there which your mind does not know, so eyes also cannot see. But that's a problem. When he opens his mouth a little wider, he gets pain, stretches it. So we have to take certain precautions when we are handling patients like that. I'll come to that later. Then pain and temporomandibular joint. This is a very hot topic of today. Like in Mumbai, maybe here also. Lot of seminars being held on TMJ, temporomandibular joint. Now what's the reason? It's one part of the dental anatomy which the dentist should know very well is being neglected. It's really being neglected. I'll ask over here, I'm not taking a viva, but I'll ask you, how many of you all actually check the temporomandibular joint? None of us. We take it for granted normally. When you have a problem, then you think, "Arey, ye to dekha nahi." So patient has a problem, and there are a number of patients who say that they need to have dentures for the joint to be at rest. When it's overclosed, there can be a positioning of the condyle in such a way that there is pain. Does a prosthodontist work alone? The success of a complete denture can never be alone. It has to be in relation to the dentist, to the lab, and to the patient himself. This example I'll give you. We have a few patients who walk in and it's okay, examine the patient. Now when I go in, patient says, denture बहुत अच्छा है. Denture बहुत अच्छा है. I see the denture, underextended, very, very loose. But the patient is keeping it in his mouth very, very well. Why is that happening? Why is that happening? It's happening because the patient is accepting whatever denture he has and he is keeping the denture and retaining because of the neuromuscular control. Not the denture is good. You followed? So the patient plays an active role, not that you have to allow him to continue with the denture, but when you prepare a denture, a lot of emphasis has to be given to the patient and patient needs to be told how he has to retain the denture in his mouth. That's a very important thing. Whenever we are given specs to wear, we are told, if you are wearing something to read, then you keep your specs here. If you have a bifocal, keep your specs here. If I have a bifocal and I keep my specs here, I'll say no, that person who made my specs is not good and I'll not be able to read. But what has happened is the instructions have not been given properly and you have not involved the patient in the treatment which you are offering him. So make sure that you involve your patient. So your success of a denture only comes when you involve all these three. And most of us in the colleges are doing our own lab work with the help of the laboratory assistant. But I request the postgraduate students to try and do their lab work for a complete denture patient. Even today, if I have to deal, I don't always work on patients, on complete denture patients because students are around and I go, maybe I see the step and go away. But if I have the management person come and he says, you do the complete denture, right from the time I start with the impressions, to pouring the impressions, to doing the arrangement, to doing the insertion, I do it myself. Because I'm so paranoid that my technician may not pour the borders properly, may not do the flasking properly, may not do the packing properly, may not do the curing and I get porosity. Then he removes the denture, he breaks it. So all those things go on in my mind and say, okay, better do it myself. So I think the postgraduates should learn to do it. If you learn to do it, we in colleges, I think sir also has come from colleges where we all had to do our own lab work because it is there where you learn what not to do. And you can find fault with your technician what he has not done. If you don't know how to do an arrangement, if you don't know how to do a carving, if you don't know how a tooth should be placed, I'm sure you cannot tell the technician. So I say take support of the technician, but you should be responsible for what goes in the patient's mouth. You can always ask the technician to do your arrangement as a dentist and comes to you from the lab, then you do modifications for that patient. We'll come to that when we're talking about how to place the teeth for the patient. This is a very important statement and I love it. We always talk about perpetual preservation of the tissues. Don't we? I think it must be written somewhere in the corridor also. Perpetual preservation of what remains rather than meticulous restoration of what you want to do. That was Diva's definition and we always said, don't put too much of pressure, try to protect the tissues, whatever, don't prepare teeth. Now we say, okay, be conservative in preparation of the teeth. Because we want to preserve what is there with the patient and we don't want to do just a meticulous restoration or a prosthesis for the patient. There's one more definition I picked up this lately. I love this definition. A dentist should meet the mind of the patient before he meets the mouth of the patient. Why the mind? Because sometimes you are worried in your own way, you have some other problems happening, probably madam ne chilla diya, patient nahi aaya, ghar mein problem hai, I have not paid my fees. So many things go on in your mind. When the patient is talking to you, you're absolutely lost. So what you have done, and you know it's very unfortunate, we don't understand this, there's vibes of an individual are very, very important. Aapko kabhi pata chala, you walked into a room, there are 10 people in the room, and you look at one person, bada acha laga. एक पर्सन को देखा खड़ूस है, ये देखो ये बड़ी स्नूटी है, ये भी देखो बड़ी स्वीट है, बड़ी अच्छी है. क्यों ऐसा लगता है? Some people's wavelength matches with your some people's aura matches with your aura. Some people's doesn't. Doesn't mean they are bad. It's just that it doesn't match. So what you have to do is you have to get yourself to the frequency of that patient and then start with the treatment of the patient. So you should meet the mind of the patient before you actually start. And the most important step in a complete denture is examination. And I'm going to emphasize a lot on this. Because we can emphasize, we can have a whole day lecture on examination and treatment planning for an implant, which a denture is going to stay even otherwise if you don't even do anything. Because it has got a clip on it, or it's got a socket on it, or it's got a screw on it, it's going to stay. But we spend so much of time in putting that killa in the bone. Sorry, Akshay sir. I call it killa because some of them don't even think what they're putting in the bone. You have to do the understanding. That's why.
किल्ला लगाने के बाद भी तो डेंचर तो बनाना है.
वही, that's my last slide. So examination and diagnosis, we have to spend enough time. Please remember, you must be having case history charts with you all. All of you have. But when you become dentist, will you have that case history chart? No. But what you will do is, you will be a better examiner of examining. You do a better examination for the patient and diagnosis because you know all. But today you are learning, so you need to have a proper examination, each step written down. We say no, we want to do some work, we make I should do note on my mobile, a note, we have a mobile note, I have to do this, I have to do this, I have to do this, yes? The same way we are giving you a chart which you should follow. Why you should follow, then it becomes systematic. And it's unfortunate that we become dentists and we have our own practices and then we forget the chart. But abroad, I have been to a lot of clinics. Probably the system is a little different and they have a lot of insurance and that's why those papers are important. Here we don't have insurance, so we get away with a lot of things. But we need to have paperwork and paperwork. You say that? Why we said those three things? What succeeds? Only paperwork. Paperwork will succeed always. It can be on a computer, it can be on paper. Paperwork means documentation. So you need to have documentation for all patients. Suppose after a few years you want to refer to that patient, you will say, okay, his first denture had good retention, but this denture did not have. Why was it? You say, okay, that time also he didn't have very good ridges and he's a diabetic patient. So probably there's a lot of bone resorption which has taken place and this denture is not going to fit as well. So you can refer to your notes. And I was just talking to Dr. Akshay and he told me that when he left ITS, all the patients of your implant, he had given all the information of those patients, the time they placed the implant till the time he left. That is documentation. So you need to have documentation. We are only lacking in two things in our country. I've been to so many universities abroad. Whenever I go to the States, I just have a lot of my students who are there, so I call them up and I'm coming to your college. I go there, spend a whole day. Knowledge, par excellence, Indians. Par excellence. We have a lot of knowledge. IT, we are very good. Two things we lack. I would say three things. One is documentation, one is sterilization, dedication. Three things. हमारे पास सब कुछ है. ये तीन चीजें हो गए ना, we'll be on top of the world. And our own students who go there, they have all these things. They have all these things. They are very dedicated. They get up in the morning at 6 o'clock and run to college. They are there till 11 o'clock, 12 o'clock doing lab work. They are very dedicated. And there, without sterilization, nothing will work. And documentation has to be there. So these three things. So that is why examination, diagnosis and treatment planning for a dentures patient is very, very important. Now the first point is general information. Second will be chief complaint. I'll go to that in detail. Patient's expectation, medical history, dental history. So why, madam, we're talking about all this? Because each point has a lot of relevance. General information. How do we get general information? You first observe the patient when he walks in the clinic. I am not taking sophisticated patients purposely because we have to have compassion for the poor. And I picked up most of the patients who are the poorer lot of patients. And just imagine if the poor patient doesn't have money to pay and he walks in and you treat him like he has no money, so I don't do good work for him. So my bottom line to my students is always, उसके पास ₹1,00,000 का नोट है, होता तो नहीं है, that's why you also don't have it in your, he doesn't have it in his pocket. ₹1,00,000 का नोट है, and your denture treatment, he's going to give you 1 lakh. Imagine how you treat that patient. IA, that year. Yes, no? Won't you do that? You will do it, huh? Don't say I'm very good, I won't do it. You will do it. Alright? Because money pays and money speaks. And I was telling Dr. Akshan as well, coming in the car, I said, it's never been very important. Money has never been very important to me. But it's important. It's not very important, but it is important. So even when you are treating a patient, it is important. You're not going to treat a patient free. But you can set aside few patients who you will say, I will do their work free. And there are a lot of dentists who do that. They say, okay, Tuesday is my day for free treatment to dentists, for free treatment to patients. And then I'm telling you, there are a lot of dentists who are doing this work. Every patient need not be a paid patient. They say, okay, तुम वहाँ पे go, वहाँ पे there's a place, you can go, उनका, they have some NGO organization or they have some committee, वहाँ पे चले जाना. You know whatever work is done in those type of clinics, they do नाम के वास्ते, or they send them to the clinic. So even those centers which run on a lot of funding, sometimes if you don't have the will to do good work, you will not do it. You can do it in your own clinic, you can do it in your own college. So always observe the patient when he's walking. Because your patient are not to you, still you can observe. Patient comes, sits in. How is he walking? Just by his body language, you can come to know so many things. So many things you can come to know. You can come to know from what state he is, what type of a feeling he's having, whether he's depressed or whether he's happy, how is he walking, is he tilting on one side, whatever he's doing. I think this must have been told to you when your case discussion was taken with you, but we are revisiting it today. Aren't we revisiting? Complete Dentures, we are revisiting. And I'm just trying to re-establish the fact that you need to do this. You need to observe the patient. Your confidence is important in treatment. Your confidence means some of you are staff, some of you are students, some of you are postgraduate students. Now, you may be a third-year student, and this is the unwritten law in our college, that no staff will shout at the student in front of the patient. Because that patient does not know whether you're a doctor or you're a student. A lot of educated patients know, but a lot of patients don't know. But if we scold you in front of the patient, then the patient definitely morale goes down. And he says, पता नहीं किसको दे दिया, पता नहीं इसको कुछ आएगा कि नहीं आएगा, पता नहीं कैसा टेंशन बनेगा, तो कभी अच्छा होएगा ही नहीं. So you know what? Everything starts playing in his mind. And even if you've done good work for him, he'll not be happy. Alright? So your confidence has to show. It has to show. You should be a good listener. How many of us are good listeners? Good listener?
They will be after marriage.
Unfortunately, a lot of girls here, sir. So, good listeners, very, very important. I tell you what. I'll give you a lot of examples in between, so the conversation, the lecture will be a little light. Good listener means let the other person talk his heart out. In between, you're wanting to say something, you're trying to interrupt. Hold back, hold your horses. Why? Because when he's talking, let him talk his heart out. तुम उसके बीच में बोलोगे तो उसका डायरेक्शन बदल जाएगा. He will not be able to talk. Be a good listener, and then you'll realize that what he's telling you is making so much of sense. But a lot of us are not good listeners. Like even I'm not a very good listener. People start talking and I start giving my comment in between. अरे उसको खत्म तो करना था पूरी बात खत्म करेगा तो ही मुझे समझ में आएगा ना what was the end of the story. But I've told the story in between only, which is not it. Okay, so be a good listener. Your communication should be very simple and should be in a truthful manner. Whenever, see what has happened, unfortunately, I'm spending a little more time on this because for your practice this will be very important. Unfortunately, we are pushing treatments onto the patient. We are pushing treatments. There are a number of times when patients are poor and we could do a complete denture, we say implant the time. Give him options. And give him truthful options. Not because you have to make money. Yes, you will make money. Money to aayega. You do one good patient, I'm telling you, if you do a sincere practice, after second year of practice, you will not have to call patients, they will come to you. Because they will realize how truthful you are. If you are not truthful, in whatever you do it with your heart. Jo bhi karna hai, dil se karo. If you start talking to him and talk to him with your heart, and tell him that this is the problem, we can do this much for you and no more, then he will be much happier. Otherwise telling him that yes, I will give you a very good denture and everything will sit very right, you'll be able to dance with the denture, you'll be able to eat everything with the denture. After a little while he'll be dancing with dentures in hand. So we cannot promise the moon to him. So understand that, always be truthful in what you're telling the patient. Now just the name and all. This is all, every day we do it, we take the name of the patient, everywhere, all forms you get name, borough, age borough, occupation borough, address borough, habit borough. But why is it important for you? This your secretary can do it, but you are a student, so you do it yourself. If your secretary has done it, you will get all this information before the patient walks into your clinic. But if you have to do it, you have to start writing from the age of the patient, name of the patient. Why name is important? Anybody knows? Naam to documentation ke liye. You have to have, you know what, when patient is called by his personal name, he feels, doctor मुझे personally जानता है, देखो ना इतने patient है उसके पास, पर वो मुझे personally जानता है. So please read his name before he walks in. That is one thing. Ask his name. Age is very, very important. There are some young patients who are also denture wearers. Why did they become edentulous? What can we do for them? There are some old patients who are denture wearers. They have other problems. I'll come in the next slide. Occupation is important because sometimes the occupation, maybe he's an orator, maybe he's a singer, maybe he's the flute, he plays the flute, he plays the mouth organ. So he uses some part of his mouth for that. So he needs support. So if you take occupation, he's an orator, and I remember when Bajpayee ji used to talk from the stage, I used to always think, किसने denture बनाया इसका? I always to feel, you know. I said, क्यों इसका denture अच्छा नहीं बनाया? इतना क्यों सीधा बनाया? You know, because they made such a low vertical for him. Probably he had all resolved teeth, ridges. That's why probably they could not give him the correct vertical dimension. So I used to always say, he's such limelight, why can't they give him a better denture? And Murarji designs denture, nobody knew he had a denture. You know, किसने बनाया था denture उसका? Manjeet ने. Manjeet was his patient. You all will not know, orthodontist Manjeet. He was my batchmate in the army, and we used to always say, I made a denture. And I said, लगता नहीं denture बनाया इसका. So it used to look so nice. Then address and telephone number is for making money. You have to know where he stays, in which area he stays. Greater Clash is supposed to be elite area. Yes? वहाँ रहता है तो थोड़ा ज़्यादा पैसा दे सकेगा. वो अगर कहीं और रहता है तो we don't know how much maybe some. Don't ever judge the patient by the attire. Never judge the patient by the attire. Patients who are in dhoti have more money than people who are in suits. And that it's very misleading. So I remember one patient. All these things come back to me because I remember one patient, a very poor patient, and we were trying to not tell him about the implants and all. And you know, he asked us. He said, no, poor patient, like, you know, he's dark looking, poor villager. And he said, हमारे लिए implant हो सकता है क्या? Marathi he asked me. So then I said that, but उसका बहुत, I mean, it's expensive. Like, he took out a bunch of, you know, packages in his pocket and he says, इतना पैसा है, tell you what. Not a private, it's college. So I said, this man is so rich. And like we are underestimated, it's a long time back, and from that time I learned my lesson. If a person is well dressed, maybe he's taken a loan and bought all those clothes. Okay. So it's like habit. I'm just telling you this, don't do it. Because we are supposed to counsel patients who are having tobacco habits. So habits, if he says that he is a pan chewer, tobacco, areca nut, at once start thinking what I have to see in his mouth. That is the reason. Baki habits I'm not bothered about, what other habits he has. But especially tobacco, alcohol. So smoking actually denture can help him protect his palate from inflammation. But that doesn't mean that you can tell him to smoke. Okay, and then age. When the patient's age, as he grows older, there's always a decreased capacity of tissues to tolerate any type of stress. Not this stress. Okay? Now if you're putting a denture or placing a denture on tissue, you have to know this patient is old, his tissues are fragile. So keep that in mind, because what are you doing examination for? What is examination? It is like a police officer investigating. It's a police officer investigating. And then, after your investigation is done, you assess it. That is your diagnosis. Alright? So investigation and assessment. There are two things that you should be good at. So when you're doing all this information is going into your computer. And then your computer will start saying, okay, this particular case, I must do this. How is that happening? Because you are assimilating all that information at the moment. Then tissue takes longer time to heal in older patients. Why? When I was young, my hair used to grow very fast. I'm old, hair don't grow only. You put oil, not talking about myself, talking about the patient also. Why does it happen? Because you see, nails used to grow very fast when I was young. Now nails don't grow only. So if these things are happening to an older patient, definitely the healing process in an older patient is slow. But you've forgotten that. So you unless you take warm water, you take a lot of inflammatory, you take tissues which will irritate the material which will irritate the tissues and place in the mouth and expect the patient to be happy. No, you have to be careful that you do not injure the patient in any way because you are going to expect a longer healing period. Many diseases are prevalent in old age like diabetes, kidney problems, heart problems, all these will be. So they will be related. When we come to any type of medical history, we say age of the patient, I would expect all this to happen. Then women especially, women who are in their above 50, ask them whether they are going to the menopause because in those cases, not only the tissues will be inflamed, but there will be other psychological problems also for the patient. Not that men don't go through andropause, but we talk about women more. So men, we have to understand even their psychology at old age. There's a little different psychology for both men and women as they grow older. Now we won't go to the psychology part because every sect has its own set of problems and we have to tackle them in a way that we give a successful attention to the patient. Then especially men, as they grow older, their confidence, they are retired, they don't have a job. He was the boss of Mahindra & Mahindra. Today he doesn't have a job, nobody says hello to him, nobody looks at him. He says, "Arey, main to itna bada aadmi tha," nobody looks at him. His confidence level goes down. So age, all this will tell you about the age. And if I know a patient is of a certain age, I will also select his teeth accordingly. I will do his waxing and carving accordingly. I will select the base accordingly. I will try to tell him what I can do for him to get a successful denture. So all this will come when I start talking to the patient. Occupation, I said it's a must. Because any modifications you want to make, you can actually at the trying stage of patient, we had a patient who used to blow the flute. He was a flutist, Basuri. So he used to get that flute and used to say, at the time of trying, we have moved upper teeth and lower teeth in and out for him to be able to keep the flute in between the upper and the lower teeth. Actually it is a little bit out, it's on the lips, in between the lips, but the teeth have to support the lips. And the teeth were not able to support the lips, so he was not able to, hold the flute correctly. So if he is a flutist, you have to know that what you can incorporate in it while you're preparing a denture. So all this is going into your computer. Most important, chief complaint, which I mentioned a little before also, patient's own words. You must write in his words. We are always telling that, even in medical history when we are taking, we said write in his own words. There is no retention. It's not his words. Denture in loose end. Write in his words. Whatever he says, write that down. Try to analyze what he is saying. What is his complaint? Why is he seeking the treatment? I told you, all want to look good. So try to find out what he wants. For eating he wants it for looking nice, or he wants for the comfort. I said temperature joint comfort. Assess if the patient's expectations are realistic or he's asking for the moon. Understood this part? If he is realistic, he knows that if you're wearing a slipper, it is not a part of your foot. A slipper is not a part. If you have a strap at the back, it retains it. Otherwise it can fall off. You have a clutch. Clutch is a support. It is not a part of the patient. If you place periodic implants, it does partly become a part fixed, so it's the patient's part. It becomes a part of the patient. So it doesn't come out whenever he talks. But in this case, you have to make it very realistic that complete dentures have certain limitations. If you want, later on we can place the patient who can't afford too much, we can still place implants for him. 2 implants are more than enough for a good oral denture. We can do that, we can tell him this. And the last is, if not realistic, educate the patient. The patient has got submucous fibrosis, or he's got xerostomia. You know the denture is not going to stay. So you start educating the patient from now. Don't ever tell the patient at the time of your denture insertion, this was the problem. Because once you have not told him in the beginning and you tell him afterwards, it is your problem. You have been inefficient in preparing a good denture for him, and that is why the patient feels that you are inefficient dentist. Understood? But if I tell him, नहीं ये होगा ही नहीं ऐसा, this can be never give him very elevated आश्वासन to the patient. Don't say that yes, okay, this I can do for you. Always make it a little lower. Then you say patient आएगा नहीं, दूसरे के पास जाएगा. No, realistic. Tell him the realistic facts about what you can do for the patient. Don't give him untrue picture of what you can do for the patient. Beware of patients like this. Many of you must be having patients like this. They don't come with dentures in the mouth, they come in a bowl or in a bag. Or in their hand. Or they got 1 denture from here, 1 denture from here, from the table. And then I ask him which denture you're wearing. Iska upar ka, iska niche ka. So then I wonder, I said, how is he wearing? There's no confusion happening. So if a patient like this comes to you and you prepare a denture, please put some marking inside the denture while flasking. Write his name and say, this is the denture which I've given you, I'm going to wear this denture now. Otherwise, he'll be wearing one of yours and one of his and one of the other doctors and one of somebody else. Maybe not even in his own, maybe his wife's denture. We don't know. It's coming out of dentures in his mouth. So these type of patients you have to really be aware, because when we go to the psychological part of the patient, we realize that why we should be aware. So now we've got a chief complaint and everything, and you've realized where the patient fits in. So we put him in all these categories. A patient who's, will listen to you, the psychological type of patient who will listen to you, whatever you're telling you to do. Exactly, patient will be more particular, okay, baal aisa hona chahiye, daant aisa hona chahiye, all that. Indifferent patient, he does everything, he'll blame you. He'll blame you for whatever is happening. He's indifferent to the treatment. If you ask him, ये दांत अच्छा लगता है? हाँ ठीक है. Then बाद में ले लो, ये तो दांत अच्छा नहीं है. This tooth is too white, this is too dark. So you have to try to understand at this particular stage where he fits in, and then start psychologically handling this patient. Okay. And the last is skeptical patient, उसको कुछ भी करो पसंद नहीं है. But never ever put your patient in the last category. Put yourself in the last category. I always say when the patient comes after many denture patients coming once or twice for a recall, then what does student come and tell me? Madam, psychological problem. All of you must have done that. Madam, go down. Patient is not cooperative. He doesn't want to wear the denture. You are not looking at your own problem, what you have not done for him, but you are blaming the patient. So you become the skeptical patient, I feel. So never ever put your patient in the last category. That is the category which does not exist for me, a skeptical patient. But there are patients who are like that, who will form opinions from other dentists, other treatment. Usne aise kiya tha, suppose you are making an impression in alginate and other dentists had made it in compound, then he will say, okay, that dentist had made like this, but aap to aisa kar rahe ho, ye to galat hai. Because he knows everything more than you, and he has assessed that dentist also, he has assessed you also. So there are patients who are like that. So in such patients, always tell them what you are doing and why. Okay? Then medical history. We always lack in this. We just take it for the sake of taking. We take it also. We take the medical history also. But when we are planning the patient, we don't take this into consideration. So make sure that all that is going into your computer, into your brain, you utilize it maybe for an impression. If a patient is diabetic, what are you going to do? Whatever teeth will you select? I've taken a case afterwards to discuss that with you. Then cardiovascular disease. This I want to just tell a little bit, even for complete denture patient and even dentureless patients. A patient who is a cardiovascular patient is always on medication which brings about dryness of the mouth. I had a priest who was my patient, and I remember one of my PG students just had done some crowns for him. And after 3 months, the patient came back with the crowns crumbled down. And the tooth, the crown was in the hand and the teeth underneath were crumbled. Once it happened, twice it happened, and I started wondering that this patient, kya problem? Why is this happening? We had not taken the history properly. The patient was on anti-coagulated drugs and he had gone through a bypass surgery. So the medication which he was being given, that was bringing about dryness of the mouth, and that led to caries. And the caries was under the tooth, under the crown which we had given. And we put him on a mouthwash, a fluoride mouthwash, and we told him at least 3 or 4 times in a day you should do the mouthwash. The patient did not have a single tooth after that crumbling down. And we told him that every half an hour you must sip water. Why you sip water? Because God has given us saliva. And saliva is what? Is protective. It protects the teeth against caries. People who have got dry mouth, why do mouth breathers have multiple caries or rapid caries in the anterior region? Because of dry mouth. So we forget about it that dry mouth can lead to caries because there is no protection. That's I'm talking about the patients who are with teeth. But those patients who are with complete dentures, their retention will be a problem. There will be a sticking of the cheek to the surface of the denture. And these type of patients should never be allowed to eat chiku. You know what is chiku? That fruit chiku. You read an article on that. Patients who are having less amount of saliva, and if you give them chiku, you find a layer forms around the denture, and that makes it so slimy, sticky that it sticks to the lip, and that dislodges the denture. Okay, so these patients should never be given chiku because the mouth is absolutely dry. Neuromuscular disorders, maybe the patient having a Bell's palsy or paraplegic patient. Now these patients you've already observed when they have walked into your office. When you've walked into your office, you've already observed them. Now if you have not taken this into consideration, the patient has a Bell's palsy and you're trying to record the jaw elevation, when the patient says this is not gone down. And you keep on thinking that why I'm not getting the parallelism between the ridge and the wax rim and the interpupillary line. But you have not realized that this side of the face is not active at all. So these type of patients should be given some type of oral physiotherapy, and simple exercises can be given to these patients. These are simple exercises for physiotherapy. Alright, so these type of patients, and last is radiation. You should know about radiation. A lot of cancer patients come to us after radiation. And at least 6 to 10 months should pass before you start any denture treatment for radiation patients. Remember that. Even if it's a complete denture, because tissues are very fragile. And do not put extra load on the tissues after the radiation is done. Then the current medical history, if he's on any insulin, anticoagulant, you have to be careful that don't have any sharp instruments working on the patient. Is there any I already said that the patient is having any hypertensive patients, dry mouth. If he's on corticosteroid, again his dryness of the mouth is there, patient is confused, his behavioral changes are there, and anti-Parkinsonism. If patient, have you ever seen a patient with Parkinsonism? Parkinson's patient dekha? Anybody has seen a patient with Parkinson? Yes, you have seen that. How difficult it is to make that patient sit in a chair and even make an impression, and especially if he's got more amount of movement, difficult to take a jaw relation, and what are you going to do for that patient when you give the denture? So make sure that you assess that patient today. Dental history, why? Why I said Parkinson? I just complete that. Parkinson patient will be, we also call it a wandering mandible. It can happen even in patients who are older in age and who have not had a denture for very long. Those patients can be, but if Parkinson patient is there, you find those patients very difficult patients for retaining denture and also for taking any type of a step like jaw. The dental history, loss of the teeth, emphasizing a little more on the history part, and then I'll go to the actual impressions and which type of impression should be made. Loss of teeth, now I go and look in the patient's mouth and I find the ridge is absolutely resolved. I ask the student, how did the patient lose the teeth? Madam, he had caries. A patient with caries will not have resolved ridges. First time. He has had a periodontal problem, that's why there is resorption of the ridges. Because there was a lot of recession which happened and then the teeth fell off. Or it can be a combination of both. But a patient who has lost his teeth because of caries will always have massive ridges and irregular ridges. Then the patient, how long the patient has been edentulous. Very important point. If the patient has come to you immediately after extraction, you will have unhealed ridges, but he will be a better patient for a complete denture because his muscle coordination will be there. He still not lost his muscle coordination. Another patient who has lost his teeth but not had a denture for say over 6 months. He is also a good patient because ridges are healed well and the coordination of muscle is still there. But you have a patient who has not grown his denture for very, very long, has not come for a denture treatment for very, very long. Now he is a very bad patient. Reason is that he has been eating with his ridges, he doesn't want a denture, His children, for the grandchild's wedding, want them to make a denture. So he doesn't want it. If he doesn't want it, why are you forcing him? He should want a denture. Only when the patient wants a denture, only then you should plan and give a denture to the patient. Never try to give a denture to the patient forcefully. If such a patient comes to you who does not want a denture and he has to only stand and smile in a photograph for a denture, to tell him, "ठीक है, for the happiness of your children, we'll make a denture for you. Try to wear it during the wedding, and if you want to wear it, you wear it, and just come back to me, and then I'll try to improve on it." Give him an option. When you give him an option, he'll definitely try to wear the denture. Then previous denture wearers. Previous denture wearers are those patients who have already had dentures and they already assessed dentures, and they have multiple problems, which at the extraoral examination, at the end of the extraoral examination, I will be talking about how old denture wearer you can assess for the denture stability, whatever. Because we always forget. Whenever I ask the patient, is an old denture wearer? The student says, hard. He had an old denture some years back. Where the denture? Ghar pe. Have you assessed the denture? No. Are you going to improve on the denture? No. How do you know what he had and what he wants? So we will go to that after this. Extraoral examination, general appearance of the patient, very, very important. Facial symmetry. Why is it important? None of us have exact symmetry of the patient's face. None of us have. How will the patient have? But this is some symmetry is always there. But it's absolutely asymmetric, then you might have to incorporate some type of a plumber outside. Maybe this part is depressed and you want to make this part more permanent. Then probably you can give a plumber on that side, or you can arrange the next set of teeth on that side. 2 layers of teeth are arranged on that side to make good support for the cheek. So you have to find out whether there's any asymmetry of the face, or maybe because of palsy it can be. What type of lips does the patient have? Skin, I'm going to do muscle tone, neuromuscular coordination, and temporomandibular examination, temporomandibular joint examination. General appearance, look at the patient. How he looks, whether some patients walk in and you feel they look very pale. Absolutely pale. Then you start sending the patient for an examination, medical examination, and find out if he has any other health problems. Because you know and I know how much of sterilization in prosthodontics you maintain. Okay? So facial symmetry. Then according to the classification, you can have, how many of you all have ever noticed your own face? You have? Okay. What about face do you have? According to this classification, a round, square?
I have an ovoid face.
An ovoid face. Are you all ready to accept that she has an ovoid face? Yes? Anybody else? No. She has more square ovoid, you see. It's a more square ovoid. It's not, ovoid would have been a little more rounded. Okay, it's a square ovoid. So you take this into consideration. Alright. So try to analyze this when you're watching on TV or watching cinema. So you don't have to look at this part, look at this part. And you will realize that why is the form important? Because what you do after jaw relation, you go take the jaw relation to your sister is a nursing staff or the laboratory. That's it. Right, wrong? How many of you all actually select the patient's teeth? I'm talking to the students. PG? You select your own patient's teeth? Come into PG with me, okay? I'm impressed. I'm impressed because I'm telling you what the students do. They just take the jaw relation record, and that also there's no marking. And they go to the sister in my lab, sister, daant chahiye. I walk in and I say, daant chahiye? I said, have you considered anything else? Hey, madam, denture karne ka daant chahiye. I said, daant chahiye, but you try to understand what the patient will. By fluke, sometimes you put a denture, try in patient's mouth, and says, very nice. I said, looking very nice. I said, what did you consider in this patient? Then they look at me, what did I consider? Nothing, wo fluke se ho gaya. Fluke se ho gaya, because it so happened that sister gave you a set which matched with your patient, and the patient's whole composition was looking very, very pleasing. But it was not you who thought about it. Alright, but I'm sorry, you must have thought about it. So I'm happy that at least one person said in this whole gathering that I do select my own teeth and my anterior and posterior teeth separately. So try to classify your patients. All this which I'm spending 1 hour is a 10-minute job when you know everything. When I go look at a patient, I say, oh, I look at the history. He tells me the history, he's missed out on 2 things. Why have I remembered? Because I've seen everything in one glance. I don't have to take a mirror. Form kya hai? Residency kya hai? Mid-parietal traffic kya hai? No. You look once in the patient's mouth and you have to know it all. So, extraoral examination. Profile, I don't know, people don't understand what is profile. You know what is profile, na? You stand like this and the shadow falls, ye jo aata hai, that's the profile. Okay, that's the profile of the patient. So please remember, people don't know what is profile, they don't tell me. I don't know, my students are not have been understanding what is profile, that's why they tell me, profile means this. Not profile. Profile is a side view, always remember. It's a side view. They will always tell you whether the patient is a retrographic, prographic or a normal case. Now for you, every case is normal. Yes, every case is normal because you cannot make out. Because you never try to see which points have to be considered. If you consider these points, you will exactly know the patient is a prographic, retrographic or a normal patient. Now most of the complete denture patients, if they have had a denture for a number of years, do become prographic. Okay, why? Because the maxilla always resorbs internally, from outside inwards, and the maxilla resorbs externally, from inside out. So the lower jaw becomes wider with age and upper jaw becomes narrow with age. Now, when the patient came to you earlier, he had normal resolution, so you gave normal arrangement of teeth. But when he came for the second denture, you realize that I have to either I have to take a 0-degree arrangement or I have to do a lingualized occlusion. I cannot use the same anatomic arrangement for this patient because now the jaw relation doesn't appear the same as it appeared earlier. Lip. Very, very important point which we miss out. And this happens at the time of denture insertion. At the time of denture insertion, suddenly you realize, I'm talking about a college because I'm there, madam, denture insertion. They say denture delivery. Now I don't know which person delivers, but they call it denture delivery. Denture insertion. We go there and I just stand and I said, my God, I said, how many teeth are visible? Madam, short upper lip. Short upper lip teeth can be visible, but you could have masked a little by reducing the vertical, the visibility of the upper lip. At what stage you could have done it? But you did not. At your examination diagnosis, you never did anything. You never realized that when the patient was smiling, his upper ridge was being seen. Just yesterday, and I was in the clinic, so I said that, okay, one girl came, so madam, patient technique, over-denture patient. 2 canines jutting out, over-denture patient. So I went there, I said, you want to do over-denture patient? I got the root canal done, I want to do over-denture patient. I looked at the patient, I said, take a jaw relation and tell me whether you can do an over-denture for this patient. The upper ridge is almost touching the lower ridge. Upper canines have extruded so much that even if you cut the canine till the gingival level, they will still be seen because the patient has got a bimax and the upper lip is short. Can you think of giving over-denture in a patient like that? You can't give a denture in that patient unless you do some type of a modification in teeth arrangement. I'll show you that patient afterwards. I mean, I've just taken the anterior area to show you how you should trim your teeth and place them. So please make sure that the lip is assessed at the time of your diagnosis and treatment planning, and you can tell the patient that, see, when his own teeth are visible, chalta hai. But when your denture teeth are visible, nahi chalta hai. You yourself will realize. To the picture, you can measure out. If it's 20, it's normal. If it's 22 ke upar, it's supposed to be a long upper lip, otherwise short upper lip, below that. Now, this is for normal patients, but if the patient is well built and long, big face, then you can't judge. So, your upper lip, if it is very long, and especially as the patient grows older, which lip becomes more prominent? The upper lip. Upper lip starts sagging. Not prominent, but it starts sagging. And this tissue also starts sagging. So, upper lip becomes longer and lower lip, the lower teeth get more visible. So, you have to realize that in such cases, you can't say that my upper lip should be visible 1 to 2 millimeters. So, what you have to do is you have to assess that patient. If this patient is 80 years old, if I make the upper teeth visible by 2 millimeters, he's not going to look good because at that age no upper teeth are visible. But lower teeth can be visible a little more because in lower, the sagging of the lower denture lip takes place and teeth are visible a little more. So judge the lip length, very, very important. You said what stage? Again, at this stage you can check it, but sometimes when the lip is flaccid, then you can check it at the jaw relation stage also, and you can put more support or less support to the lip at the jaw relation stage. If it's being supported too much and you find that the lip is looking natural, then you can continue with it. This is one thing. I had one very pretty looking lady, a patient in Nagpur, 88 ki baat hai. And she was Mrs. Kolte. I still remember her name because she was a very pretty looking lady and elderly. She was about 75, and her only problem was that her fold should be operated. What should I do with a patient like that? So you have to observe that she has those nasolabial folds exaggerated or not. How many of us have done that during our patients? Only when we look in the mirror and we see this is more problem, oh, I'm prominent or that. But what can we do? We have to tell that patient. And I still remember that even if we try to put the lip out by increasing the lip support, we were not able to remove the wrinkles. I mean, I told her that she had an old denture, and I said, we'll not be able to do it. She said, no, but I want to look good, I want that. I just asked, I said, see, age changes are taking place in the body, and these are age changes. You have to accept certain things. Hair cannot be white, cannot be black at old age. Your joints cannot be normal at old age. So this is a part which you have to accept. So if you tell that patient the realistic state of his tissues at this stage, you will be much more happier and the patient will be happy. So skin color, again skin color is very important because you can't have a dark looking patient with glaring white teeth. Even if you take dark teeth, the teeth appear white in the patient's mouth and they look very, very bad. I don't know whether you observe these things, you know. I remember this Coffee with Karan. You used to watch that? Who watched Coffee with Karan? All of us used to watch it. Earlier, about 3-4 years back when Coffee with Karan started, did you observe this Karan Johar's teeth? Karan Johar's. He had new laminates and I know who did that for him. Even Rishi Kapoor had laminates for or crowns or laminates, you could just see that. And they used to look really bad. Because when they would smile, there was a flash of whiteness. Probably they got them changed now and they look better. They did not match with the patient's face color. And he tried to judge with auscultation that what he could hear, crepitus, or he could hear a click in the temporomandibular joint. So we as teachers are going to emphasize on the examination of temporomandibular joint. Reason being, where is the postgraduate sitting? Yeah, okay. Now when you all are having your Gothic arch tracing patients, when you apply the tracers and you start doing Gothic arch tracing, you call your teacher, "Madam, you're tracing नहीं देता है? क्यों नहीं देता है tracing? What's the problem? Because that patient was not meant for a Gothic arch. And when I go to Gothic arch, I tell you, why do you do Gothic arch? We have taken tentative centric and we are going to do a final centric. What nonsense? That's all nonsense. Gothic arch is only a method of reporting. You have to understand that. So if a patient does not give you coordinated movement, how do you take a tracing? So if you at the examination time try to understand the movements of temporomandibular joint, you can simply put your thumb here, ask the patient to go forward, backward, side to side. If he does this, you can go for a Gothic arch tracing. Tracing, depending on the intermaxillary space, if you have or you don't have, depending on whatever traces I'm going to put. But please check the movement of temporomandibular joint. And you have to know Amitabh Bachchan to know who he is. Otherwise you cannot. Maybe if you are blind, you can hear. Okay? Then Amitabh Bachchan ka awaaz aisa hai. Or maybe with your hands you can feel. So the second will come feeling. So you have to do digital. Now if I say digital examination, my new generation only knows mobile digital. Okay? So digital examination doesn't mean that. When we were young, digital was this. And that's why it's called digital. Because our fingertips are used for doing all that work. So digital examination means feeling of the patient. And the third is the radiographic examination. I always tell my students, please don't come with a radiograph. Madam patient, kya hai? I'm telling you, all of you will do that. And we also like fools look at it and say, iska rukna ke liye bhej do. You know, the older generation, means mere se pehle wala generation, would actually scold us if we showed an X-ray to them. My teachers always taught me this. X-ray, radiograph is an adjunct. It is an adjunct. It is like your blood test. It is not the only type of examination which you can do and come to a conclusion. It is an adjunct examination. Adjunct means what? In addition to. It is not the only examination you look at and say, okay, aaj se ke liye bhej do. You cannot do that. So all these examinations put together, you can start with your examination. Now first thing, why should you examine the cheek? So old example I'm giving. Cheek should be examined. Depending on the cheek, the buccal flanges, what happens to the buccal flange and the tissues in that particular area. Maybe the patient doesn't have, but the cheek is going to be dictated by the buccal flange. So you need to examine the buccal flange and say the patient was an old recent extraction case. And you look at the buccal mucosa and you find that there are all indentations on it. What would you think? The patient did have some type of cheek bite. So when you make a denture, you be careful that I don't arrange my teeth more buccally so that I don't get the same thing with the patient. And if sometimes when you have the lower jaw out, you tend to take the upper teeth also out. And again, one example of a patient. I had a patient who had a very small jaw. Lakshmi Bai. She was a very old patient of mine. And very small jaw, very cute looking lady. And she came back for a checkup and she said, I'm getting pain. She would say, I'm getting pain. So I examined her, there's no lesion anywhere. I took out the dentures, placed one of the dentures in position. Pain hai? No pain. I removed the denture, put the upper denture in mouth. Pain hai? No pain. Put both the dentures, pain. Now, I was young at that time. Probably I did not know what to see because my mind was not knowing. When I said, why is she getting pain when I put both the dentures in the mouth? There was a cheek bite which was happening. And I had given her, she had a very small jaw, very narrow ridges, and I had given her 0-degree teeth. Now in 0-degree teeth, this problem is always there because the horizontal overlap is not there. So always give a horizontal overlap in 0-degree teeth. If you don't give a horizontal overlap, cheek bite will happen. I just went a little off because I want to tell you about the cheek. Examine the cheek well. Opening of the stensil duct also gives you a position of your molars. So if you know the position of, just observe it. You have to observe. क्या बोलते हैं ना? When we say when you do meditation, I don't know how many of you do meditation. How many do meditation? Akshay sir, let's say meditation. Not a single person does meditation, or you're shy to tell me. I'm really surprised. Today the only thing is meditation. Only thing is meditation. If you want peace of mind and if you want to be happy in life, you have to do meditation. Alright? Think of what I'm saying today. You laugh at me today, but after a few years you'll say, Madam, I think meditation. Kya hota hai meditation? I like go to the pub, I like to dance. And you can dance in meditation, you can go to the pub in meditation, but you can spend 5 minutes with yourself. How many of you spend time with yourself? I see people standing at the lift and उसकी friend खड़ी है side पे, उसको ही message कर रही है. क्या हो रहा है तुम लोग ऐसे? ऐसे बात करो भाई दूसरे से, message कर रहे हो? That is not right. So I'm going a little off because I feel that you need to know about each other well. You cannot just think of being in the world without doing meditation. I'm just meditating something I went off this back now. Okay. So buccal opening, location of many lesions like lichen planus, submucous fibrosis. Now we have submucous fibrosis which go undetected during the examination. When you start making the impression, you realize the patient can't open the mouth. Can't open the mouth. So what do? You've not examined the patient properly. And here you are suffering now. You don't know. You only know the habit, but you've not seen. When you are taking the habit of the patient, at once when you're doing the oral examination, you have to say, I have to search for this. Because he has been having tobacco, I have to search. I'm sure there will be some lesion there. So you can have different lesions. You can have a leukoplakic patch, you can have lichen planus, you can have a submucous fibrosis, candidiasis. In old age, diabetic patient, candidiasis is a very, very common condition which can occur. And how we handle it, I'll just talk about it. I've taken the treatments a little later. I'm just examining the patient now. Tongue. Large tongue. Why do you have a large tongue in a complete denture patient? I told you 3 categories of patient. Patient with period dentures for very, very long. One patient 6 months probably, and one patient recent. Which one would have the largest tongue? The one which is recent and he has lost all his teeth at the same time. Suppose he lost his posterior teeth earlier, there would be fanning of the tongue. Suppose he lost his anterior teeth and posterior teeth together and he's a little older in age and a lot of time has lapsed, you find that tongue is such an organ that it takes a lot of visits. Okay? And very difficult for a prosthodontist to bring it back into position Unless it is got back in position, your denture will be a failure. It has to get narrowed down. How will it get narrowed down? It's muscles. What is tongue? Tongue is a muscle. If you try to control, don't you control under muscle? Even this get controlled. So your tongue, you don't have to do a glossectomy to make it small. But it can be housed and the patient will have to be explained how to position the tongue if it's a large tongue. And if it's a large tongue, you will never ever select a Gothic arch tracing. If you take up a Gothic arch tracing for a large tongue, you have to be careful how you're placing the tracers. Remember this, what I've said. When you're placing a Gothic arch tracing, you've got a good ridge, you've got enough intermaxillary space, the coordination muscles are there, but the tongue is large. What do? So I place my tracers without reducing the lower rim. I will reduce the upper rim and place my tracer so that my tongue will be housed in the lower between the tracer, intraoral tracer, central bearing plate and floor of the mouth. Normally it should rest and relax. You know what happens when you give the patient the denture and ask him to open the mouth, he puts his tongue at the back. What is happening? We are losing the seal on the lingual side. So the patient from the first day of his appointment has to be told how to locate his tongue. You tell him that he has to keep his tongue like this. Not at the back. Because if you check the retention of your lower denture, you will always have to ask the patient to relax and place his tongue in the floor of the mouth. It should come in contact with the lingual surface. Only then you'll be able to check for the retention. Why? Because the seal will not be completed on the lingual side. Right? So be careful about the tongue, and if the patient has a tongue which is very, very, very small, then it becomes difficult for you to get a seal of the lingual side. The size of the tongue, the position of the tongue, always ask the patient to keep his tongue in the floor of the mouth. The attachments are very, very important. Now, this is a very good point I want to discuss here is, you examine the patient and you see the freni. Freni are a fold of mucous membrane. Anteriorly, labial frenum doesn't have any muscle, buccal frenum has muscles, the same in the lower. Now, muscles are there, but how would you know that I have to record this frenum or I don't have to record? There are some freni which are present and not active freni. Some freni are very active and this will push the denture down. So when you have a frenum which is very active, you have to actually stretch the tissue in such a way to see that the freni are active or not active. If they're not active, it's okay if you don't record them. But if they're active, you have to make sure you mold the tissues in a particular way to house them in your impression. Very, very important. Suppose you have a frenum which is right up to the crest of the ridge. You have a classification of freni given here, class 1, class 2, class 3. If you have it right up to the ridge, you can imagine that this patient may have had an old denture and there was always a fracture in the center taking place. It could be because of the frenum which was attached right to the crest of the ridge. So if you have a frenum which is attached and you are not able to house it, then you need to have a frenectomy done. Or you make an impression in such a way that you can house the frenum. And the floor of the mouth. The floor of the mouth, how many people know what's plica? What is plica? Anybody knows what is plica? Anybody? One Cadbury for them. Plica. So floor of the mouth is never looked into. Never looked into. It's not.
And whenever you
What's this last thing? This 2 minutes. I want to finish with it. 2 minutes. If they're getting late now, we can stop now, finish with this.
whatever is comfortable, we are ready.
Please continue.
Okay, thanks. The floor of the mouth. I said if people don't know plica, you will go back. Now that we have Google God with us. Who's Google God? Google. The Google God. I have students sitting with me and suddenly I ask them a question and one of the guys is not looking at me, my PG student, and then I said, why? He said, क्या कर रहा है तू? कौन पे अभी? No madam, the answer to brother. Answer to brother. God. It's okay, as long as you get your answer. So everybody is going to find out what is plica. It's a fold of mucous membrane on the lingual surface of the ridge, lingual surface of the ridge, in the floor of the mouth. Now it may have some ducts passing through it, and sometimes it is really very, very prominent. Now if you don't observe it, you will not be able to record the lingual flange of your denture. That means your impression will not be able to record. So you need to see the floor of the mouth, the level of the ridge. The level of the ridge is to the floor of the mouth, or the floor of the mouth is higher. Sometimes in the floor of the mouth you have genial tubercles. Have you observed a poor ridge? I said no, we have so many ridges. We still would have not been able to see a case where the ridge is so poor that you have the genial tubercles prominent. If the genial tubercle prominent, you have observed, digitally also you have seen, you find that it is prominent, note it down. If you don't note it down, and with red pen just mark it up. So when you mark it up, what you have to do at the end of the history? Just look at all the red points and say, okay, these are the points I must incorporate while preparing my denture. Then the greater ridge resorption is taken place, floor and lingual genial tubercles and mylohyoid ridge become very prominent. Now tell me, anybody who has ever given relief on the mylohyoid ridge while doing the packing of your denture? Not as many. I'm telling you no. Because when you palpate on the lingual side, note it down, especially with the pieces I'm telling you this, when you're palpating the ridge, you're going lingually and palpating the mylohyoid ridge. Now at times the mylohyoid ridge is so prominent, you cannot end your denture at the mylohyoid ridge, you have to go below the mylohyoid ridge and get a seal. Now that mylohyoid ridge, when it is prominent, you have said prominent hai. But at what stages did you take precautions? Right at the final impression stage? Then you put a relief on the final cast, the tinfoil relief. Maintain the tinfoil relief till your packing is done, so that you get a relief in that particular area after denture insertion is done. Alright? Genial tubercles are prominent, note it down. They have to be covered in the denture because between the ridge and the genial tubercle, there is always hard tissue and the ridge is resorbed. Genial tubercle become prominent only when there is resorption of the ridge. So your denture will always end beyond the genial tubercle, never between the genial tubercle and the ridge, because there is no resident tissue, and your denture has to rest always on resident tissue. Suddenly you give a denture to the patient and you find you got a swelling here. Why is it got a swelling? You have covered the duct. Sublingual duct has been covered. And patient says, denture पहनता हूँ तो swelling आता है, denture निकालता हूँ तो चले आता है. So if your mind does not know what you have done, you have overextended the denture, and definitely you have a covering on the opening of the duct, and the patient has a problem. Another thing is you can also check whether the patient has any stones in the ducts. This can also be done by giving him what? Candy. Candy तो अपने पास भी होता है. We can give a lozenge. Give him a lozenge and let him all fingers on the tikha, so that there is saliva which is excreted and there is swelling. There is swelling, definitely you can send him for a radiographic examination. We are going to have a radiographic examination, but this will enhance. Okay, I have to look for that stone if it is there. Maxillary tuberosity. Now, this area very, very important, which we miss out. Always miss out, and when the denture construction is being done at the time of the jaw relation, you find that the upper base and the lower base is touching. And then you say, oh, the tuberosity is so large, what do I do? But if you had observed it at the time of your examination and treatment planning, probably you would have sent him for excision after taking an X-ray, so your antrum is not opened up over there and you don't have an oral antral fistula, and you get the repositioning of the maxilla, and then you can start with the denture. Not enough, there's not enough space, and this always happens in another case where you have the combination syndrome, where you have the maxillary tuberosity dipping down, and this will happen when the last tooth is lost very late in life. Undercuts. Do you ever see this in the patient's mouth? No. No, I'm telling you no. If you don't see it, we see it when we find the denture is short in that area, and the teacher comes to examine the denture. अरे नहीं तो short है. क्यों? Because there was an undercut in the maxillary tuberosities, and the patient's mouth was open. You could not take the impression. Extending beyond that undercut, and you landed up with a short denture. Or you had an undercut, you went through, you made a nice denture. Denture inserted in the patient's mouth. Patient, both the upper and lower denture inserted in the patient's mouth. Patient cannot open his mouth. What's happened? There was an undercut. You put a denture flange over it. Now the cornoid process is there, which is not allowing the denture flange, not allowing the cornoid to open. Have you thought of that? That means your examination was wrong. If you had done an examination correctly, you would have said, okay, I will not get place for the denture flange. I need to have an excision done of this undercut and then proceed. Second is that if you have an undercut in the anterior and posterior region of the mouth, try to always preserve the anterior undercut and remove the posterior undercut. Now, which side would I remove? Always try to remove the larger undercut. Again, I have undercut on both the sides. Same amount. Which side I will use? I will use the side the patient, opposite side patient is a chewer. I will say which side is a chewer? Ask him when he lost his teeth. The side he lost his teeth last, that's the side he was chewing. So he will still chew on that side because that's the engram. That's the way patient always chews. So he will start chewing on that side, so you keep this side undercut. Remember this what I told you. That how do you decide which undercut to keep and which undercut to remove. Then you have undercuts on the lingual side. The lingual side undercuts, because of the mylohyoid ridge being prominent, I said you can relieve the mylohyoid ridge, but sometimes the undercuts are really, very prominent. And you note it down, you may not be able to remove that undercut because we rarely ever modify the mylohyoid ridge. Because patient who's come to it that age doesn't want to go through a surgery. Then you can think of giving a soft line in that particular area and keeping the denture flexure out. Hard palate, again, the U shape, V shape, it's not much of a problem, but if you look at the mouth and you find a V-shaped palate, at once you will say that I have a problem. I will not be able to get good stability of the denture, so I have to take certain precautions. As soon as the denture dislodges a little, I will have a lot of gap, the V-shaped palate, I will find that the denture will fall. If I have a flat palate, what precautions I am going to take in the flat palate? After a real closeness of contact, after a very good impression, I have to make sure the posterior parietal seal is effective so that I will be able to get good retention. If I have a U-shaped palate and parallel ridges,